Hi, everyone. Thank you for joining us once again for our weekly webinar on preventing and managing COVID-19 in the workplace. I'm speaking to you from rainy California, so we're happy to have these raindrops coming down. Some of you probably don't appreciate how nice it is to have some rainfall after a drought, so we're happy about this. This is our 46th consecutive webinar, and we're shooting for 52, so we're closing in on our goal. And then we're going to reevaluate how we want to continue after that, but we know there's going to be an ongoing need for information. And as always, we really appreciate your participation. This is Karen O'Hara. I'm the Director of Marketing and Communications and the moderator for today's session. The session is being recorded and you'll be on mute for the webinar. Please submit your questions using the Q&A function and we'll address as many of them as we can as time allows. Those of you who join us every week know that we always post answers to all questions on our website on the COVID-19 page at workcare.com, including those that we don't get to during the session. We also post the webinar recording on the WorkCare YouTube channel. So you'll find that's a great resource. Our presenter, as always, is Anthony Harris, MD, MBA, MPH. Dr. Harris is board certified in occupational medicine. He's our Chief Innovation Officer and Associate Medical Director for on-site clinical operations. He's also our lead clinician for WorkCare's COVID-19 response. So I'll turn it right over to him. Thanks again.
Wonderful. Thank you, Karen, and thanks everyone for joining once again. 46 in a row. We're not stopping anytime soon. So we'll jump into today's presentation, which is gonna throw some of you for a loop. And that's what we want to do in terms of keeping you on your toes, thinking outside the box of things that can be helpful in the workplace in regards to preventing COVID-19 transmissions. So we'll jump right into the format as usual, starting with our clinical update, followed by our pathology, microbiology update. We'll jump into the epidemiology numbers, both locally in the US and globally, see how we're faring against our neighbors. We'll talk about some prevention, some strategy as well in regards to what WorkCare brings to the table and what your clinicians locally might be offering as well. So without further ado, we're going to start throwing you for that loop I mentioned with the clinical update. And today's clinical update ain't about humans. It's about these guys, canines, right? And we want to talk about canines. We'll explain why in a second. I'm going to leave that as a cliffhanger for now. But we're going to talk about what is the clinical presentation of COVID-19 in our canine friends. Now, some of you may already be glimpsing forward as to why we're talking about canines. If you don't know, we're going to make it clear for sure and get deep into these wonderful additions to our potential strategy to address prevention of COVID-19 in the workplace here. So when we talk about canines in particular, pets in general as well, what does the CDC have to say about whether or not we should be concerned about canines being affected by COVID-19? So we do know there's evidence of canines, cats and dogs as well, that have become infected with COVID-19. And it's mostly due to contact with people who are positive for COVID-19. And we know that there is little risk for spreading COVID-19 from animal, canine to human, all right? We know originally that COVID-19 in Wuhan, China likely came from a bat source originally, but and when we're talking about other species transmitting COVID-19 to humans, it's unlikely, and we don't know of, if any, too many cases in which this has occurred. Now, with that being said, we do know that, again, spread of COVID-19 can happen from people to animals in certain situations. So what do you do about it? What do you need to know in addition to this? We need to know that these animals, again, don't serve as a reservoir for transmission again to humans, right? But they may suffer some of the same symptoms, which we will talk about here shortly. And we also need to know that more studies need to be conducted and presented to fully understand what the transmissibility from animal to human is at this point in time. We also know that when you have someone who's positive for COVID-19, they should avoid contact with animals. So not only isolating in the household from your household members, but also your man's best friend and your pets, because again, they can be affected by COVID-19. So this is something we want to share with our workforce. Because we have family members, right, that are furry in nature, and we want them to be safe as well. Obviously, we don't need to be overly concerned about any transmissions from our pets to our humans. But we're talking about this topic in particular because it's germane to a strategy that we and you might have seen already in regards to screening for COVID 19. Finally, what do you do again if you have a pet that's positive for COVID 19? Just like you would as a human, you need to isolate the pet. Again, low risk of transmission from animal to human. However, it's still recommended from CDC that you isolate appropriately, and by all means, keep that pet calm, keep that pet hopefully fed and hydrated, and they'll do fine. There is no evidence, or there hasn't been any severe disease that's caused death of pets or canines in this case. So most pets recover after being infected. You don't have to use any crazy astringents or alcohols or anything like that on the pet that would just potentially harm the animal. So we have a full picture now and understanding of what we should do with pets. Again, isolating that pet at home is the right play if they become infected. So, what are the symptoms that a pet may have? Fever, cough, just like in humans, difficulty breathing, that lethargy or malaise, we call it, where they're really sluggish, you see their behavior change. They can sneeze, have a runny nose, some discharge from the eyes, and certainly the GI symptoms that we see in humans can present in animals, vomiting and diarrhea. Okay, so if you haven't guessed it by now, what we and why we're talking about canines in particular, it's because one of the strategies that is playing out in the US, in Florida, the Miami Heat, are using canines now to screen the fans that will be attending the games, basketball games, with canines, right? And one of the concerns that you'll hear come up is what is the risk of that canine, one, contracting, and two, transmitting COVID 19 if it picks it up from an individual that as they're in close proximity to, trying to ascertain whether or not the human is positive for COVID-19. So we want to get ahead of that. We want to communicate effectively to the population, to our workforce, the risks that may exist or may not exist, and be accurate in our understanding of is there any efficacy to this phenomena we're seeing with across the pond. We'll talk about that, as well as playing out now in the US. So let's jump into the pathology and let's dig into, again, more about the utilization of canines, in this case, to screen for coronavirus with the fans in the Miami Heat arena. And if we think about it, right, we know that canines have been used in similar scenarios clinically. Canines have been used to detect cancers, Alzheimer's, Parkinson's, also detecting skin abnormalities as well. So when we talk about the use of canines clinically for screening purposes, there is history that goes years back in doing so. And we have reports that we'll talk about, and as early as July of last year, pointing towards the efficacy of animals, canines, for use in this regard. So your workforce will see this in the media, and they'll ask questions, and that's why we need to know about it so that we can prevent, hopefully, any misinformation around this type of modality of protection in the workplace. So let's get into the nitty gritty of efficaciousness, right? Anatomically, physiologically, is it even possible for a canine to detect COVID-19? The answer to that lies in the anatomy of a canine. And a canine has about 250 to 300 million olfactory receptors, smell receptors. and they lie in this area of the nasal passage. And this nasal passage is very convoluted, meaning it's very torturous in its makeup intentionally because there's a lot of surface area in this space. So compared to humans, which have about 5 to 10 centimeters, cubic centimeters of mucosa that can pick up smell, a canine has 170 square centimeters in their nasal passages, much more, right? And then if we look at then the kind of basis for detection of smell, it starts in the mucosa, in that mucosa area, and then followed by connection to nerves that connect ultimately to the olfactory nerve, the olfactory bulb. And these are the far more numerous connections than we have in humans. So we have about 5 million connections for our olfactory sense, whereas again, dogs have 250 million to 300 million. So again, the dogs are able to pick up on small molecules that we'll never be able to pick up on, small scents. And if we look at what potentially they are detecting for COVID-19, it's not the virus itself. And we'll talk more about clinically what studies have looked to provide evidence of the canines being effective at screening for COVID-19. So let's jump into the numbers. Let's look at the epidemiology here in the US. Let's see where we are, where we have been over the last 2 weeks, and in fact, where we are today. So we were 22 million infected, almost 23 million 2 weeks ago, jumped almost to 24 million last week, and well over 25 million this week as of today. And that rate being 50.1 now out of 100,000 across the US. If we look at the deaths, obviously the deaths have continued to climb at a rate of 1 per 100,000 2 weeks ago. As we jump towards 400,000 almost last week, we stayed at the 1, and we dropped a little bit down to 0.9 as we crossed over almost 420,000 deaths per 100,000. And does that represent an improvement? Perhaps, but we'll see over time how this metric changes in regards to, are we making progress or are we losing ground still with regard to effect of death in particular from COVID-19. If we look at daily new confirmed cases in the US and our neighbors over the last 7 days on a rolling average, we can see where we were 2 weeks ago as we declined a bit last week, and we have a little bit more decline here this week, right? And so that's a good sign, right? If we continue to see this decline, then it may signal a change in either how we're protecting the general public, the mode of transmission, et cetera. And we'll continue to draw inferences from this as this trend has been for 2 weeks now, heading in a downward fashion. So when we look at per million, however, we know the United Kingdom has been and remains ahead of us per capita 2 weeks ago. They also saw a decline last week. And if we look at it this week and we compare to Spain and Portugal now, we can see where we stand compared to United Kingdom, dropping now below us, right, in the daily new confirmed cases per million, and Portugal and Spain still on the increase trend that we're seeing. So we'll continue to watch them and see how they fare. With regard to deaths, we can see the decline 2 weeks ago in the US. UK was climbing at that point. We continued to eke up last week, and the UK kind of started to plateau, and then dramatically has an increase this week when we talk about comparing to per capita the deaths. We can see where we are. Excuse me about the doubling back there, but we can see where we are in comparison to the United Kingdom over the last 2 weeks as well. When we talk about deaths per capita, this is where we were last week and where we are today in terms of per capita deaths, still well below the United Kingdom. You see Portugal and their impact from COVID-19 in regards to deaths as well. Jumping to the tests, the number of tests, still not a rosy picture. 2 weeks ago, we were declining. Last week, still hovering around that 1.4, just around 1.3 million tests on a 7-day average. And it's not looking any better this week. still hanging out around the 1.4 million, 1.3 million tests on a 7-day rolling average. If we break that down, comparing to our neighbors again per 100,000, we can see where we fare, declining still 2 weeks ago, and this week still in that same position. Uh, there we go. So declining over the last couple weeks there per capita of daily new tests. If we look at then the percentage of tests that are positive, again, an important metric to continue to watch. We understand that this is a metric that tells us if we're accurately articulating the burden of illness in the US. We have not been. And 2 weeks ago, we were not. We're still over that 15% or right around that 15% mark. And if we see where we are today, we have declined a little bit more down towards 12%, which is a good sign, right? We also know that we have some small decreases in the number of cases that may correlate to detection of actual cases and our testing ability. But again, we'll need to continue to watch this metric to truly understand what that picture is telling us. If we jump to vaccinations now, we can see where we were a week ago with 31 million distributed doses and about half of that being administered. And those who received one dose was 13 million, 13.5 million. Two doses was only 2 million. So if we jump to this week, we've increased from that 30 million to 44 million, and still half of that approximately being administered. So that trend of administration versus distribution hasn't moved, right? And if we see the 19 million that have received one dose, and we've only bumped up 1.5 million roughly for those who have received two doses. And we have heard, I'm sure all of you heard the bottlenecks in regards to distribution and logistics and supply. So now we're talking about the supply of vaccine not being adequate to get that second dose. Some people having to wait weeks, with the CDC coming out with new recommendations around no maximum wait time or no maximum time period between dosage. So we know these trends are changing. These recommendations are changing, both in regards to what the science says, that there truly isn't a maximum time period in which you lose efficaciousness of administration of that second dose, but also a result of what we're seeing with regard to supply and distribution and logistic bottlenecks that exist state to state. If we look at globally how administration is going of the vaccine, back on the 13th, this is what the picture looked like overall, with the US having dosed over the numbers that we just presented here. Fast forwarding to today, the 19th of this week, really, we can see where the US stood and where we stood in comparison to the United Kingdom. If we look at then where we are, that was back on the 19th. Again, this is today, well over that million mark. And we can see the United Kingdom is still increasing compared to our neighbors in France and Spain. And we can see Portugal, hardest impact from a death perspective per capita, and their administration not really taking off yet. If we break it down per capita, United Arab Emirates was in the lead in regards to that number, US trailing behind. We fast forward to last week, and then finally this week, we can see we've made a little ground. We took off the UAE since they were so far ahead. We wanted to compare to United Kingdom and their administration per 100 people, and they're doing pretty good. And we see how Portugal has increased over time in their administration per capita. So now let's get back to what we were getting at earlier in regards to prevention, right? Utilizing a screening methodology that some may say is a little unorthodox, but we'll make an argument of why it makes sense in certain situations to adopt such a strategy. The science behind it, when we talk about studies conducted to ask and answer the question, do canines make good screeners for COVID-19? And if we look at this study in particular that examined over 1,000 samples utilizing a number of dogs, a number of canines, we can see that in this case, what they were suspecting is that the canines were picking up on what are called volatile organic compounds, okay? These are VOCs, you may be familiar with that terminology in environmental health and safety in general, but we produce VOCs as a result of infections, and we can have our canine friends detect those VOCs. And let's see, we'll examine, is that detection accurate? And if so, how accurate in comparison? So this study, again, looked at over 1,000 samples and a number of canines, and they found that the diagnostic sensitivity was 82.6%, meaning that if an individual, or in this case, a sample, was positive for COVID-19, the dog detected it 82, almost 83% of the time. If we look at specificity, it was even higher at 96.4%. So, in short, what we have seen in this study, that was at the time back in, again, this our article was in July of last year, that it was pretty darn accurate. And if you recall the PCR test during this same period in time, the accuracy was actually lower on average, under 70% sensitivity in a lot of the PCR tests conducted at that point in time, and certainly a specificity under 90%. So our canine friends can, at the end of the day, in this sample of 1,012 randomized samples, produce results comparative and even better in some cases to our PCR studies that were conducted. If we look at the rejection rate, or how often they got it wrong, right, we can see that 157 correct identified positive samples, and 792 were rejected as negative accurately. 33 were incorrect in terms of calling it negative, and 30 that were positive were rejected as well. So again, high accuracy for this particular study. If we look at another study that examined 8 dogs, we can see that in this study, again, the protocol was not, real quick, I'll back up. This study looked at, in particular, swabs, nasopharyngeal swabs, as well as saliva samples from people that were positive for COVID-19. Okay, so it wasn't the dog was going up and sniffing the individual, it was the samples were provided, and that's how they conducted this study. Whereas this study looked at not saliva samples or nasopharyngeal samples, but sweat samples. And in this study, a total of 8 dogs, there were 18 dogs originally in the study. They used only 8 at 3 different sites to examine whether or not the dogs could detect these sweat samples from individuals, in this case, hospitals. 198 armpits, in this case, axillary samples were collected. And the results were, again, aligned with what we saw in the previous study that sorry, I skipped ahead there. That 100 for a number of dogs, about half the dogs, 100% of the time, 100 of 100 samples were accurately detected. And the other 4 dogs, respectively, were 83 out of 100, 84 out of 100, 90 out of 100, and 94 out of 100. So again, we're seeing high accuracy. Their conclusion was very high evidence that even sweat, that again, we produce VOCs that is apparent in our sweat, can cause a canine to detect COVID-19 for an individual. If we see then where this rubber meets the road, so to speak, or I should have said where the paw meets the floor or the ground, we can see that this is playing out in locations such as Finland, Helsinki, in the airport locally, that canines have been used for a number of months. And if we examine the particulars of this particular operation, we can see that 100 travelers over the course of a day, 2,200 per month, have been screened for some time, since September of last year. And the accuracy is almost 100%. And that's even 5 days before actual symptoms appear in these individuals with COVID-19. So in practicality, we can see that canines can serve as good screeners for COVID-19 at scale. And we can see why now the Miami Heat are looking to adopt this type of methodology to protect the fans that are going to be populating that stand. So how does it work? Is it practical is the next question, right? And if we look at how Helsinki Airport conducted their operations, we can see that it's very, the dogs are very capable of detecting within 10 seconds. an individual that is positive. The whole process takes less than a minute to complete. Right. So first, can you scale it? And the answer to that is yes. Secondly, is the process invasive? Does the dog have to get in the face of individuals or whatnot? And the answer to that is no, it's quite simple. The passengers are taking a swipe of a cloth across their skin, collecting that sweat, and they drop it into a container that's in front of the dog. And the dog is sitting behind a wall and with their trainer, and they sniff that sample just like you would be swabbed on your palm at the airport for any kind of explosive residue on your palms, right? That process we're familiar with, and this process is very similar, only instead of a machine reading for VOCs, we have a canine detecting VOCs for COVID. So again, this process is executed, has been executed at scale across the pond, and we are now seeing it play out here in the US. We're excited to see how it's going to play out with the fans down in Miami. So, what does that mean for us in the workforce? Is this a strategy that we can look to help protect our workforce? And the answer is possibly, right? Vaccination and validation and screening combination could be a good solution as we move forward through 2021 and we have more of the workforce, particularly in that 1B zone that's now starting to get vaccinated as the essential workforce, in addition to a low cost screening methodology that may play out very well here very soon. So, what could that look like? It could look like this, where we have still in place the symptomatic and exposure screening that at this point all workers should be doing, and that's on a digital platform, right? And that digital platform is capturing people before they show up to work. If they're remote, obviously that's going to continue to be very important for that remote workforce, and that's followed by then some type of on-site screening. Certainly, we know you're conducting on-site screenings at a lot of your locations with boots on the ground. So, could we augment that on-site screening now with a low-cost, high-accurate process utilizing canines to then screen workers that are high risk? And so, what do we mean by that? So, if you have a workforce subsegment that you know is going to be in either confined spaces or in a situation in which they can't social distance appropriately, or let's say you're one of our clients that have had in place the social distance devices that are alarm when you're in proximity within that 6 feet zone, and you have the data to show which segments of your population are potentially more proximal to each other, then you can screen those workers with the canine methodology and make sure that those high risk individuals are as safe as possible with regard to detection of COVID-19. And then having a confirmatory test, obviously, thereafter for anybody who screens positive with this canine approach would be necessary, right? So the canine approach is not the end all be all. It has not been in Helsinki where it's played out live over time. The confirmatory PCR test or a pool testing methodology, if you have a significant number of people being screened positive, can augment or confirm that the screening protocol with the canine when someone does screen positive. And then if we layer on the vaccination validation process, we've talked about this briefly with regard to WorkCare's ability to track state to state who's been vaccinated in the workforce, validate that for you, document any clinical appropriate information to understand someone's vaccination status fully, and then recommend them being put into a low risk category so that they are not subject to the same level of screening that those workers who may be at higher risk currently have to complete, right? And so we can put all this together and provide then a low cost solution that may be even lower cost than a full out pool testing strategy, right? Now, we don't have yet the data to support a full scale canine operation. We'll be probably still several months from that recommendation, if it ever comes from CDC and FDA. However, we know that as we see the Miami heat execute with this methodology and we have the data that streams from it in the weeks to come, we may see more adoption of this methodology. And certainly we will be scrutinizing the data clinically here at WorkCare so that we can appropriately recommend the best strategy for your workforce in particular to their scenario and their situation. So with that, hopefully you had some fun learning about something that you didn't expect or may not have expected today. We can certainly talk more about the nuances that have happened since last week with the vaccine and with tracking. But let's go ahead, stop there, and jump into questions. Thank you.
Thanks, Dr. Harris. That was really interesting. Just wondering if we should all be investing in puppy farms or be on the lookout for Cruella de Vil from the 101 Dalmatians.
That I certainly hopefully we will identify Cruella and stop her from stopping us from doing this type of screening.
There's 3 questions about the canine friends. Is it possible pets could be asymptomatic carriers of COVID?
Certainly, it could be, right? In the same way that humans can be. Surely a canine could contract and be asymptomatic. And what we've seen in those few cases of canine COVID-19, the symptoms have been either non-existent or very mild, right? And so we know that it's possible, but again, the risk of transmission from even those asymptomatic canines is very low risk.
Okay, and one question just popped up. The dog can't contract COVID by sniffing positive COVID people's sweat, can it?
As far as we know, no. The answer to that is they're detecting and exposed to the VOCs from the sweat, but shedding the viral particles in a substantial volume in sweat is something we haven't seen thus far as a mode of transmission. It's usually the respiratory droplets that have the viral particles in a transmissible volume. Now, again, we spoke to hospitalized patients potentially transmitting through fecal exposure because the viral count is high in the fecal matter. It can be high in tears, right, as well. But again, the canines won't be exposed to those type of scenarios either.
Okay, so I just got scolded for mentioning a puppy farm in jest. And it's pointed out that puppy farms are not healthy for puppies, and I didn't mean to offend anyone, so I just thought I'd mention that. Let's see. We had one more about the dogs. Oh, it's about artificial nose. Are there any studies where an artificial nose was used for COVID detection?
So the terminology artificial nose could be interpreted as gas chromatography or gas spectrometry, right? And we know that there are kiosks that have been developed by, I believe it's 2 different universities at this point in time, in which they can detect from breath the viral particles themselves. So they're not detecting necessarily the VOCs that the canines are, because we haven't necessarily identified yet what those VOCs are in terms of molecular detection. However, we have the sensitivity and the accuracy to pick up on viral particles suspended in the respiratory droplets via a quote unquote artificial nose type kiosk, and where an individual through a straw blows into the machine, and the machine in a matter of, I believe it's 10 to 15 seconds, can detect whether or not you're positive for COVID. And those devices have been deployed, not necessarily at a huge scale, and there's certainly a substantial capital outlay to acquire one of those devices, and we haven't seen it scale up yet.
Okay. We're going to jump into some kind of random questions now outside the canine topic. Should businesses still be having employees teleworking? If so, how long do you think teleworking should continue in 2021?
Sure. So teleworking is still advised for bringing back individuals into the workplace. How far out will we be until that is a reality again? Good question, right? We don't necessarily know. It won't be until we have a reproductive rate that's well below where we're at right now. In some cases, we're at 1.8. In some cases, over 2.5 for individuals who are affected by COVID-19 or transmit COVID-19. And won't be until that rate probably drops below zero point 0.5, where the transmission rate, both in the community and workplace, is substantially low enough to say, all right, come back to work, right? Now, that won't necessarily be synonymous with come back to work without precautions. So, with regard to telework, if you can telework, you're going to be likely teleworking for much, if not all, of 2021 before we reach that low level of transmission rate.
Okay, here's one about surface cleaning. When you spray the workplace down with bleach, do the fumes kill the virus?
Not necessarily. So the bleach or the chlorine fumes that emanate from the bleach don't necessarily kill the virus because of it basically it's the pH that matters when we talk about bleach, right? So dropping the pH low enough usually requires the actual contact with the liquid bleach versus fumes from the bleach itself. So when you're cleaning surface, and we know that cleaning surfaces still is something that should be done if we can do it. But the impact of reduction of transmission is not substantial as we once believed it to be for surface contact, surface cleaning, and surface contamination. But still do it if you can, for sure.
Okay. Regarding the number of vaccine doses that are available, we hear they are available. So the question is, we keep reporting that half of the doses available are not administered, but the states are saying they're out of vaccine. So where are all these missing doses?
Oh, that is $1 million question for sure. And briefly, real quick, let me backtrack. I said the bleach to the bleach question, dropping the pH. I should have said increasing pH. Obviously, we know bleach is basic, not acidic. So wanted to make that correction here on the fly. In regards to those doses and where they might be hung up in the process, I have not seen any reports that can directly identify what the holdup is in regards to half of the doses that have not been administered but distributed. It's likely that they're not in a substantial kind of stockpile or one location, right? When we're talking about distributed doses, we're talking about to all 50 states. And so we're talking small numbers when we break it down, right? But in aggregate, it seems substantial that these doses are being hung up and sequestered, and they just may be in the queue in certain scenarios, pharmacies or hospitals.
Okay. What do you think about Dr. Fauci's comments on double masking, and do you think this could lead to a change in CDC mask recommendations?
So what we actually see playing out in terms of trends right now, and I was certainly opining about this in a recent interview on TV this week, is the notion that if you had access to double masking or access to an N95 versus a cloth mask, should you utilize that higher protective means to your workforce or to the general public? And the answer to that is yes, absolutely. If let's do a kind of a thought experiment, right? Let's imagine that in the beginning of this pandemic, the supply of N95 masks were bountiful, and everyone could afford to have not just one, but maybe one or two or three masks in the US. Would we have made the recommendation back then to wear N95s? I think the answer to that is yes, overwhelmingly so, because of the protective factor and the impact of mask wearing. So it plays out now that it's likely to see more and more utilization because the supply of N95 masks has increased dramatically, that more and more shall be wearing it in whatever scenario, both at work or in social setting.
Okay, regarding the vaccine, What do we know so far about the effectiveness after receiving just one of the two doses?
Sure. So the effectiveness in phase 3 clinical studies, particularly of the Pfizer and the Moderna, is around 80% effectiveness. And it jumps up to that 94, 95% when you have that second dose. And people develop immunity in approximately 14 to 21 days after that initial dose and secondary dose as well. So we know, and that's why we've seen in the UK and some early hints that we will likely see more people getting that initial dose, and the skew going in that direction versus more people receiving both doses because the protection level is substantial enough, and the numbers play out statistically enough to decrease the overall risk in the general population with just that initial dose.
Okay, and we have time for one last question. We can't get to all of them today, but I just want to remind everyone we do post the answers on our website to all the questions. This one involves a comment and then a question. The CDC has estimated that the total number of COVID cases in the U.S. is likely around 90 million people. Many of these cases have recovered and hopefully are immune or at least resistant to reinfection. There have been approximately 25 million vaccine doses administered, so there may be around 125 million Americans with at least some resistance to COVID. The daily numbers of new cases appears to have peaked, at least for the time being. Could you discuss the possibility that we are trending toward herd immunity, and therefore transmissibility of the virus is being decreased because the percentage of susceptible victims is decreasing?
That assessment is absolutely accurate in how it was articulated, meaning that yes, we are woefully, as we've been talking about in this presentation, we've been woefully underestimating the number of people affected by COVID-19 in the US. And some suggest, yes, that number is 4x or even 5x what we are picking up on with our testing protocols in place nationwide. So if we do assume that 90 million Americans or 100 million Americans have been infected and recovered from COVID-19, and we add to that the number of individuals who have been vaccinated, we still don't get to that herd immunity number yet, which is closer to over 200 million people, right? When we talked about the reproductive rate being 1.2 to 1.5, 60% of the population would need to be vaccinated to reach herd immunity. And that's the 196 million Americans, I believe. If we look at where we are actually, when we talk about more people being infected than we've tracked at a 4x or 5x, that would put the reproductive rate closer to that 5 number, right? And if that is the case, then 80% of the population would need to be vaccinated or have immunity naturally from recovery of coronavirus to reach herd immunity. And that puts us up again closer to 220, perhaps 220 to 250 million Americans. So we still got some room to go. And we can look to the trend of daily new cases on a 7-day rolling average. And if it continues to trend downward over the next several weeks to months, then that may indicate that because of that underestimation, in addition to the number of people vaccinated, we do have a population that is now at a level where the susceptibility, those who are susceptible, is low enough to see benefit, right, from a herd immunity standpoint. So how that question was worded and broken down is spot on if those assumptions are made.
Okay, great. That was a thoughtful commentary from the person asking the question. One person's wondering if next week we might be able to talk a little bit about the new CDC guidance on reopening schools. So we can maybe add that to our list of topics.
Perfect.
And anyone in the audience who has a topic they'd like us to address, please feel free to send us a note at info@workcare.com and we'll follow up on that. So we're out of time. Thanks again, everyone, for joining us once again. Wish you well, take care, and we'll see you next week. Thanks you, Dr.
everyone.
Harris.
You bet. Thanks, everyone. Stay safe and God bless.